All right, we're going to go ahead and get started. Welcome, good morning, good afternoon, depending on wherever you're joining from. Thank you for joining us for this webinar on addressing health equity in HIV care. My name is Alex Lapira. I'm with the National Center for Complex Health and Social Needs. It's an initiative of the Camden Coalition of Healthcare Providers. The Camden Coalition of Healthcare Providers is a multidisciplinary nonprofit working to improve care for people with complex health and social needs in Camden, New Jersey, and across the country. The National Center was launched as an initiative of the Camden Coalition to inspire people to join the complex care community, to connect practitioners with each other, and support the field with tools and resources that move the field of complex care forward. As part of this work, we get the opportunity to highlight the work of experts around the country on topics relevant to the field through our monthly virtual learning series. Next slide, please. All right, so this webinar is being recorded. The recording and slides will be emailed to you and will also be posted on our website. Please keep yourselves on mute by phone or on the Zoom platform. All questions and resources can be submitted through the chat feature. And please feel free to submit your questions throughout the presentation. You don't have to wait till the end. Just submit them through the chat as they come up. So let's take a moment to test that out by letting us know where you're joining from. All right, next slide, please. Okay, so here is our agenda for today. We've already gone through the introduction and housekeeping. Next, we'll hear from our presenters, followed by a Q&A and a quick wrap up. So with that, I'd like to introduce our presenters today. We have Melvin Laureano, Assistant Director of HIV Programs at the Illinois Public Health Association. We also have Mike Maginn joining us. He's the HIV Prevention Director, also at the Illinois Public Health Association. And Dion McNeal, member of the Illinois HIV Integrated Planning Council. So with that, we'll go on to the next slide and I'll pass it off to Melvin.
Hi, good afternoon, everybody. Today we'll be reviewing HIV Care Connect and how it addresses health equity in care delivery. Next slide. Next slide. Thank you. And for learning objectives today, we'll do a review of Illinois HIV Care Connect, how we align with regional and national goals, including health equity, review our program services, and information about HIV in Illinois. Then we'll be joined by Mike Maginn, who will be discussing perspectives from a long-term survivor, health equity, and enrolling clients in ADAP. And then Dion McNeal will join us to review enrolling in ADAP, health equity, from the perspective of an African-American YMSM. And we'll conclude with takeaways. Next slide, please. And regarding health equity, as a reminder for the definition from the World Health Organization, it is defined as the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. Pursuing health equity means striving for the highest possible standard of health for all people and giving special attention to the needs of those at greatest risk of poor health based on social conditions. Next slide. And regarding Illinois in particular, the impetus for health equity is visible here with key information. New diagnoses among males tend to be younger, and among women, they tend to be older. Among Latinos, new diagnosis is up 32%. And between the ages of 20 through 24 and 40 through 49-year-old MSM, it is also increased. New diagnosis among males 20 to 24 is up significantly. And diagnoses among males 30 through 39 and 40 through 49-year-old is also increased over the years. Late testers are more likely to be Hispanic Latino over the age of 40, and males with infections attributed to heterosexual contact. The rate of new infection among Black males and females is significantly higher compared to other racial and ethnic groups. Next slide. And regarding the National HIV/AIDS Strategy, NHAS, HIV Care Connect aligns its work with NHAS specifically to bring the United States, Illinois, and the world closer to virtually eliminating new HIV infections, effectively supporting all people with HIV to lead long and healthy lives. HIV Care Connect focuses on 3 of the 4 NHAS goals. Goal number 2, increasing access to care and improving health outcomes for people with HIV. Goal 3, reducing HIV-related disparities and health inequities. And goal 4, achieving a more coordinated national response to the epidemic. Next slide, please. And regarding the Ending the Health Epidemic plan, which was released by the White House in February of 2019, there are 2 overarching goals. One is to reduce new HIV infections by 75% in the next 5 years, and to reduce new HIV infections by 90% in the next 10 years. Cook County, Illinois is part of that group of counties that the EHE plan focuses on, where federal funds are designated for specific counties, and Cook County is one of them. There are 4 components of that, which is to diagnose all people with HIV as early as possible, treat HIV rapidly and effectively, protect people at risk, and respond rapidly to prevent new transmission of HIV. Next slide. And in Illinois, we have a plan referred to as Getting to Zero Illinois, GTZ, commonly known here, which was a framework developed in 2017 by a task force, including persons with HIV, advocates, service providers, prevention lead agencies, and public health department staff, with the goal of reducing HIV transmission in Illinois to a level below 100 infections per year by 2030. The GTZ strategy focuses exclusively on 2 public health strategies. One is to regarding HIV treatment to viral suppression for persons with HIV, which is suppressing the viral load in persons with HIV, leading to 0 people with HIV not receiving treatments. And the second strategy is to increase PrEP coverage and other emerging biomedical technologies for those most at risk for HIV infection. The framework stresses continuing support for the following, of which HIV Care Connect is aligned. 1, outreach, education, and marketing. 2, linkage to care. 3rd is retention, engagement, and care. 4th is medication usage, adherence. And 5, supportive services. Next slide. And the purpose of HIV Care Connect. Since 2009, HIV Care Connect links persons living with HIV to existing care consortium services with a health equity focus. Because of the disproportionate impact and inequities in HIV transmission, specifically seen among the transgender and Black and Latino men who have sex with men communities in Illinois, providers are strongly encouraged to give special consideration to these communities. And we're tasked with establishing and maintaining ongoing primary care and increasing adherence with treatment. Next slide. And what is Illinois HIV Care Connect? It is an extensive statewide network for people living with HIV in Illinois, providing medical case management, healthcare, and support services. It offers treatment and prevention services provided through a network of 8 regional offices, and is funded by Ryan White Part B grants, which is managed by the Illinois Department of Public Health. Next slide. And this slide demonstrates the 8 regions that I mentioned throughout the state. So if you look at the map, each section is designated a number, and that corresponding number matches the care lead agent in that area, such as Region 1 is the project of the Quad Cities in Moline. Region 2, Positive Health Solutions based in Peoria. Region 3, Central Illinois, managed by Southern Illinois University School of Medicine. Region 4 is Southwest Illinois in Belleville, which is St. Clair County Health Department. Region 5, Southern Illinois, is Jackson County Health Department in Murfreesboro. Region 6 is East Central Illinois in Champaign. The work there is done by the Champaign-Urbana Public Health District. And Region 7, which is the collar counties of Cook County, which is part of the EHE focus. The collar counties is also done by the AIDS Foundation of Chicago, which also handles the Chicago and Cook County region. Key things since 2009 when HIV Care Connect began, HIV diagnosis is down in the state 16%, and the proportion of cases testing late in regions 1 through 8 is down significantly. 26% of 2019 cases tested late, which is the lowest rate in more than 10 years. Next slide. And this reviews the confidential case management that is available. There are two ways to access Illinois HIV Care Connect, from a referral from a healthcare provider, or through a self-referral. Someone can go directly to our website to begin the process. Benefits include medical and case management at no charge. And the healthcare and support services include ADAP medication assistance, health insurance premium assistance, Ryan White Part B services, housing opportunities for persons living with HIV, and services are based on income and insurance status. There's also a dedicated 800 number, 800-825-3518, to receive information and to connect with ADAP and health insurance to help low-income individuals who need assistance purchasing those items. Next slide. And there are two overarching initiatives of HIV Care Connect. The first being is to conduct outreach to service professionals working with persons who live with HIV, and to link these clients to the regional HIV Care Connect programs via active referrals, so to those 8 agencies that I mentioned. The second is develop a communications program utilizing web, video, graphical, and social media strategies to encourage and guide persons living with HIV across Illinois to link to care and treatment, engage in care and treatment, and adhere to HIV treatment. So all of the visuals that you see throughout this presentation are marketing elements that are used in HIV Care Connect. Next slide. And among the healthcare and support services, benefits include outpatient and ambulatory healthcare, mental health care, oral health care, medical nutritional therapy, substance abuse services, outpatient, food bank, legal assistance, medical transportation to appointments, for example, psychosocial support, rehabilitation, and utility and short-term rental assistance. Services do vary by region. Next slide. And the image that you see in the background is an image of an event we attended recently where we conduct outreach activities with providers that have contact with individuals who may or may not know their HIV status or are not in care, or persons with HIV that have not returned for treatment services, or that do not adhere to treatment plans. Providers include healthcare and such as hospital and medical associations, social service agencies and community events, and the correction systems through their programs and conferences, such as the Summit of Hope, which brings HIV Care Connect throughout the state through their multiple events throughout the year. Through HIV Care Connect, we've reached about 4,000 individuals through our virtual and in-person presentations. Over the past year, obviously, we've had to go virtual for a lot of our work, but through that and through in-person prior to and post-COVID, we've reached 4,000 individuals. Next slide. And this slide demonstrates among the many locations that we've been to for outreach to reach individuals, either medical professionals or clients, and they include both virtual and in-person events, such as one of the virtuals that we did was the International Conference on Stigma, based out of Howard University. Illinois Unidos is an initiative regarding COVID-19, which allows us to join their efforts with our HIV materials as they conduct vaccinations throughout the state of Illinois. So key with this is to explore partnerships for new avenues of outreach, not just necessarily an HIV focus, but where you can align with other health initiatives, for example, or also knowing who else you can reach out to for additional partnerships to increase your outreach, such as the IMC logo. That agency is not specific to HIV or public health, but does manage quite a few events in Northern Illinois, and that has allowed us to do and expand our work through some of the agencies that you see here, such as the Jalisco State Office Building in Melrose Park, Illinois, which is a predominantly Mexican-American community. And so we've been able to do services at consulates of different governmental entities, also joining the Latino Policy Forum, the Puerto Rican Agenda, Latino Expo, all through the connections through IMC, for example. So exploring what those avenues are and how they connect to reach the populations that you want is critical. Additionally, we've been through, we go to college campuses such as Northeastern, University of Illinois in Springfield. In terms of medical groups, we also do work with Illinois Academy of Family Physicians, among others. AIDS Foundation of Chicago, which if you recall, provide the services in regions 7 and 8. And there is Summit of Hope as well. Along with the Black AIDS Institute, their We the People program is one of the last in-person events that we did in February of last year before the state closure. And then throughout the region, different agencies such as CWP, Community Wellness Project, and the Project of the Quad Cities are two of our most recent locations where we have conducted outreach, or we are about to do outreach there through distribution of materials, for example, with CWP and their Juneteenth celebration. And in terms of reentry programs, also there is Transforming Reentry Services, formerly known as Men and Women in Prison Ministries. Next slide. And this slide is a demonstration of the brochures that we give to people in community. They are fully bilingual, and key to this is the images to appeal to the demographics that we're trying to reach. So as you see on the left, it's fully in Spanish, and then on the extreme right, the same brochure with the aqua and yellow colors. That's the same information in English and Spanish, and then the middle panels are available in English and Spanish as well with the same images that you see there. They are available online for downloading and detailed program services, contacts, medication adherence information, website and social media that you see listed by logos at the bottom of each brochure, along with a QR code as well. Next slide. And then the next few slides demonstrate part of the campaign, one of the QI campaigns that we've done with HIV Care Connect. They vary each year, and our most recent year, which ended recently, the topic was speaking up about HIV stigma, and it's available in English and Spanish. The Quality Improvement Project gives persons living with HIV a forum for speaking up about HIV stigma, and the web pages feature persons living with HIV speaking frankly about HIV stigma, how it's affected their lives, and what they believe needs to be done to overcome HIV stigma in society, along with any type of information and resources that they mentioned during the interview. The campaign also allows others to join by hashtags hashtag HIV stigma, hashtag speaking up at Illinois Care Connect on Twitter, Instagram, and Facebook. There's also a survey that was offered on the website for individuals to complete regarding HIV stigma. So with the survey, we had about 70 respondents with that process. And all of these campaigns are not only visible, as you see here on the screens from the website, but also available on Twitter with a different design and layout as well. Next slide. And we try to capture our demographics. So as you saw in the previous slide, there was an African-American male. Here we have an African-American woman discussing HIV and older people. And with that, It also has helped, the campaign itself has yielded high increase in traffic to the website and information. So for example, for the calendar year, April 2020 through March, where the year of the QI project, page views increased dramatically, 87%. Total visits increased to 95% versus the previous year. So all throughout the year, there were different metrics, and hugely successful with the campaign and with the website, with driving traffic to website to gain more access to information regarding ADAP, as well as our Spanish pages as well. Next slide. And this slide just shows a demonstration of the Spanish version of the website, which includes the figure that you see here with their interview in Spanish, featuring a Latino from the Northern Illinois region. And then I will turn it over to Mike Maginn, who will discuss long-term survivors. Mike, you can take over. Thank you.
Great. Next slide, please. Thank you, Melvin, and welcome everyone. Health equity, or even better yet, health inequity, may involve other populations that you have not considered. And what I'm going to briefly talk about is aging populations, or better yet, long-time survivors, people living with HIV that are on antiretroviral medications and are living healthy, productive, and longer lives. Saturday, June 5th was recognized as HIV Long-Term Survivor Awareness Day. The date also marks the 40th anniversary of the first AIDS cases reported in the start of the AIDS pandemic in the United States. And it's important to kind of review just a little history of the of HIV and the data with long-term survivors. On June 5th, 1981, the Centers of Disease Control and Prevention published in its Morbidity and Mortality Weekly Report an article describing 5 previously healthy young men, all described as homosexual, in Los Angeles, who had contracted pneumocystis pneumonia. The awareness days, and I have to give credit to a long-term survivor, Tez Anderson, who started an advocacy group called Let's Kick ASS, which stands for AIDS Survivor Syndrome, to honor the estimated 300,000 Americans who have been living with HIV for 25 years or more, and highlight the unique challenges they face. As Melvin mentioned, with the HIV Care Connect website, it's a tool for clients to locate services which are near their location, number one, but where they can enroll in services and with an HIV counselor, or can enroll directly online through the AIDS Drug Assistance Program or the insurance continuation services, and gets linkage to case management. Again, as Melvin mentioned, the Care Connect website last year had over 84,000 visitors, and the ADAP link was rated in the top 10. Next slide, please. And those numbers are important for defining the health inequities, which are differences in health status or in the distribution of health resources between different groups, arising from the social conditions in which people are born, grow, live, work, and age. The data helps us understand living with a chronic disease and the societal and healthcare challenges that aging populations, not specific only to HIV, but aging populations consider. Of the 37,968 new HIV diagnoses in the US, and I want to point out that again that we had over 84,000 clicks on our link. 17% were among people aged 50 and older. According to the CDC, over half of people in the United States with diagnosed HIV were aged 50 and older. Though new diagnoses are declining among people that are older, around 1 in 6 HIV diagnoses in 2018 were in this age group. You know, people aged 50 and older with diagnosed HIV are living longer, as I mentioned, healthier lives, and because of the great effective HIV treatments that are available now. The primary transition categories of HIV in this population are, again, male-to-male sexual contact, which is 66%, heterosexual, which is at 21%, injection drug use at 9%, and then male-to-male sexual contact and injection drug use is at 3%. At the end of 2018, an estimated 1.2 million Americans had HIV. Of those, 379,000 were age 55 and older, with 9 out of 10 people age 50 who knew they had HIV. And that's a key point of being tested and knowing if you have HIV to help really curb the transmission rate so you can get virally suppressed. They also effectively, again, have no risk of transmitting HIV to HIV negative sex partners due to suppressed viral load. However, in 2018, there were 11,425 deaths among people aged 50 and older. And these could be attributed to other causes of death. Next slide, please. You know, compared to all people living with HIV, people aged 55 and older have higher viral suppression rates. For example, for every 100 people aged 55 and older, 71 have received HIV care, 57 were retained in care, and 64 were virally suppressed. But comparing that to every 100 people overall with HIV under 55, 65 received HIV care, 50 were retained in care, and 56 were virally suppressed. So whether that is maturity on the individual aging population, or if there is some kind of health disparity that's happening with the younger generation. So that's a consideration right there. There are some behaviors that put everyone at risk for HIV, and these include having anal vaginal sex without prevention, like a condom or medicine to prevent or treat HIV, like PrEP or InPEP, or sharing injection drug equipment. Although older adults visit their doctors more frequently, older people are less likely to discuss sexual or drug use behaviors. Older people may have many of the same risk factors that younger people include, but also it could be a lack of knowledge about HIV prevention and sexual risk of the aging population. Stigma is common among adults with HIV. It negatively affects getting the care, life self-image and behaviors that are not recognized with the older population. And older individuals avoid getting the care they need or disclosing their HIV status because they already face isolation due to illness or loss of family, friends, or community support. You know, and with the aging population, you also have the comorbidity or the common age-related conditions such as hypertension, diabetes, elevated cholesterol, and obesity. You know, aging can generate, again, isolation. There's a lack of advances in technical assistance and access, capability, you know, increased depression and lack of local accessible healthcare, just like, you know, basic health inequities among other populations. You know, from a more personal perspective of health inequity, it takes me back to 1983 when I just turned 30 on my birthday, and I was living in Chicago within Boys Town, and you kept hearing about this gay disease, and friends, good friends, were dying. A gentleman, Vito Russo, who helped found ACT UP, which was an advocacy group at the time. He said, living with AIDS is like living through a war, which is happening only for those people who happen to be in the trenches. Every time a shell explodes, you look around and you discover that you've lost more of your friends, but nobody else notices. It isn't happening to them, and only you can hear the screams of the people who are dying and their cries for help. No one else seems to be noticing. This is health inequity. These health inequities are based on gender, race, ethnicity, age, and sexual orientation. Thank you.
Thank you, Mike. And next slide, please. And the following slides details information regarding African Americans. For every 100 Black African Americans with HIV in 2016, 61 received some HIV care, 47 were retained in care, and 48 were virally suppressed. And as a reminder, a person with HIV who takes HIV medicine as prescribed and stays virally suppressed or undetectable can stay healthy and has effectively no risk of sexually transmitting HIV to a negative partner. And we'll introduce Dion on the next slide, please.
All
and
right,
Dion, oh, go ahead, Dion. He'll be discussing the items on the slide. You can continue.
Awesome. Thank you so much, Melvin, for the introduction. And I just want to go ahead and just take up the torch from all of the work that our previous ancestors, including the individuals who have been in this fight over the past 40 years that Mike had mentioned, and just kind of share my testimony within my journey being HIV positive, going on almost 7 years. So I'll be talking with you today about my experience being HIV positive and being an African-American man, but also going into details about this paradigm that I've coined myself called fear, stigma, and shame. I would also like to go ahead and share my experience with the Illinois ADAP program and kind of how I fell out of that and was able to really get back into that with just so much ease. And then, of course, sprinkle a little bit of my personal perspective on that. Can we go ahead and go to the next slide, please? In this slide here, we see Illinois HIV disease prevalence in 2019. As you can see, your screen has indicated right under race and ethnicity. We can see that Black individuals that are Black, we have a prevalence of 47% within the state of Illinois, but then we also see within our Hispanic and Latino populations at 20% as well. And these numbers are really scary as we look at the screen. But a lot of the factors that play into this high percentage can include things that have been mentioned throughout this presentation, such as self-image, isolation, quality of life, and the influences of that quality of life. And other things such as poverty and socioeconomic status, stigma, and barriers such as transportation and food deserts. But these are the things why we come here today to kind of address some of those issues by sharing information and sharing perspective. Can I go ahead and go to the next slide, please? And I love this panel here, or this slide. Something I've always found within myself was early on of my HIV diagnosis was a lot of fear, a lot of stigma, and a lot of shame. Some of the fear and shame that I never really knew where it came from throughout my childhood and of course, throughout my life. HIV within the Black community had always never really been discussed about. But when you look at Black culture and you look at Black art, sometimes HIV is kind of thrown under the bus, and so are the individuals, including individuals who identify as transgender. And what I've identified with this paradigm of fear, stigma, and shame is learning how to transform that into my strength, my power. And how I did that was by being transparent with myself, allowing myself the visibility to show up and show up for others and show up for the people who have been doing this work for years. And also being vulnerable with myself and being honest and vulnerable with my healthcare provider. and also with my friends and peers and talking with them about HIV so that I'm able to eliminate the shame behind it and also the stigma and more or less the fear when we do talk about HIV in public, because we've all had that conversation with individuals where sometimes they may not be as comfortable with saying HIV as loudly as we say other things. Sometimes it's a quiet conversation, and sometimes we need to step away from that. And I found that transparency and visibility, as well as vulnerability, helped me really step away from that shift my perspective on that fear, stigma, and shame paradigm. But a lot of this shift really didn't come just from myself. A lot of it came from my mentors who are within the healthcare field and who have that connection. They were able to build that trust with me and also allow me to build that trust with them in the resources that they were providing me by being transparent and being vulnerable with me and actually having those really tough conversations with me on what my reality is. I mean, a lot of things also came into play in regards to resources, access to the resources. And a lot of these tools and resources and information came from the HIV Care Connect personally from me. When I first found out, when I moved or graduated from college in 2016 and moved to Bloomington, Illinois, I was really unsure what was available to me. I didn't know where to go, who would be able to help me, and how to make that transition happen so that my medication wasn't affected, my quality of life was not affected. And when I turned to my case manager, she was able to walk me through the process and inform me what resources are available, but also create this openness where if I am having issues with rental assistance or utilities, or even mental health issues that I need help with, we would be able to discuss those things, which we were. I remember one experience where I was transitioning from a new job, a new role, and I was not able to make my rent. And my case manager was able to link me with services to help pay for my rent for the next 2 months so that I was able to get on my feet and also be able to pay my medical bills and all the other bills in my life, such as my student loans. And I've always been so grateful for that. But when I transitioned into my new job, I felt like I was at a place where I understood where I would be able to take on more responsibilities to still have access to those services. So I started to fill out the paperwork myself but still stay in contact with the resources through HIV Care Connect. But of course, life happens. And when life happened, oh my God, guys, it hit me like a brick. All of the fear, all of the shame, all of the stigma, it just kind of flew all back in. And it wasn't until I turned to my mentor, who was also a fellow member of IPHA, who was able to assist me and guide me and walk me through that process to let me know that, hey, this is what you can do right now. And this is what we're going to work towards so that we make sure that you don't fall out of care, that your quality of life is not at risk or compromised. And so I really lean into that. And I really think the guidance and the access, the community, the respect, but also the healing in this process. Because I think when life happens, a lot of those emotions and triggers can come back, and it's easy to fall back into that pattern. But I encourage and I implore everyone who is on this call to lean into those mentors and lean into those relationships, but also lean into the resources and trust that they do work. Can I get the next slide, please? Thank you. This slide here is of our amazing Georgia State Representative, Betty Price. And I want to go ahead and just point out the dehumanization effect of people living with HIV. When Georgia State Representative Betty Price was asked whether people with HIV could be quarantined, that was a great question. And she answered within the realm of legality. But her response was not as respectful, and it was more transparent than I think a lot of us were prepared for. I just want to go ahead and read what her answer was. She responded with, "I don't want to say the word quarantine, but I guess I just said it." And she goes on and says, "It's almost frightening the number of people who are living that are ... carriers with the potential to spread. Whereas in the past, they died more readily. And then at that point, they're not posing a risk. So we got a huge population posing a risk if they are not in treatment. this sort of language dehumanized people living with HIV. It forces us back into the closet, and it forces people who are not living with HIV to stigmatize, to shame us, and to look at us as these individuals who carry a risk to the greater population, when we know today that U equal U, which stands for undetectable equals untransmittable, that if a person is on their treatment, they can live long, healthy lives and pose no potential risk to their partners or to the greater public. Legally, the answer that she gave was, in my opinion, I think it was a great answer to curtail HIV, but I think the real tone of her answer came down to what are the laws within the state of Illinois. And if you're not aware, there's multiple states within the United States that still have laws that criminalize individuals living with HIV. Luckily, within the state of Illinois, we have been able to push the Health Bill 1063, which repeals the statute creating the offense of criminalizing transmission of HIV. This means that people who are living with HIV are no longer stigmatized, dehumanized by the laws that have been created in a period where we didn't have the science that we have today. And that's sort of the knowledge and the information that we want to make sure that we approach our members within political office. But more importantly, we want to make sure that we look at the laws that are within our states and how these laws are further perpetuating the fear and stigma and shame and really dehumanizing people living with HIV. Next slide, please. And what I've learned throughout my time being HIV positive and my connections with my mentors is that it takes a village, it takes a community. We can't do this by ourselves. So what I do in my time in my service with advocacy to promote health equity within the state of Illinois is meeting with different individuals who have been in this fight far longer than I have, and really kind of bring them onto my channel and talk about some of these things where we welcome ignorance, because I'm usually the person that's still learning, and I want to bring anyone I can to learn as well, because we all know that ignorance is just a place before you learn. And on my channel, I welcome that sort of knowledge, that sort of ignorance, so that we can learn together, so that we can grow together, and that we can unlearn some of these habits that we may have learned years ago, but now that we are in a time where medication exists, resources are more accessible, mentors and people are available to us. It helps us connect better as a community to really get people into care, and also maintain into care while they're learning about themselves, learning how to be living with HIV, and really turning that negative into a positive. And that's all I have today. I'll go ahead and hand it off to Melvin. Thank you.
Thank you, Dion. Great information there. Next slide, please. And Dion, as Dion mentioned, his involvement with ADAP and enrollment through HIV Care Connect. During that same period, there were 4 persons enrolled through HIV Care Connect into the program for those services. And we just want to acknowledge the following: Cheryl Ward from the HIV Surveillance Program of IDPH for the information data sets presented here today. Ray Valek from HIV Care Connect, he's the website and social media contractor via Valek and Company. And of course, Illinois Department of Public Health. The image that you see above is also more marketing in the Chicagoland and Cook County, Collier County area to reach medical professionals regarding the program. Next slide. And in memoriam, we'd like to remember the following that passed away in the past year through 2020. Bob Yeworth from Clubhouse Productions was highly involved in the African-American gay and bi community through nightclubs and other events. John Gutenson, also from Chicago Recovery Alliance. And Ramon Buenrostro from AIDS Foundation of Chicago. Next slide. And the following shows our links to our programs of HIV Care Connect through Facebook, Twitter, Instagram, and YouTube. Next slide. And a few takeaways from today. Keep in mind, you should know and focus on your state's prioritized populations. increase collaborations to reach persons living with HIV, explore partnerships for new avenues of outreach, like I mentioned earlier on, and keep in mind the visual appeal and social media to reach the population. Keep in mind CDC campaigns. If you go to the CDC website for HIV, you'll see very specific marketing elements there that is in line with what we use in our own work here. Next slide. And thank you for attending our presentation. I'm Melvin Laureano, joined by Michael Maginn and Dion McNeal. And I'll send it over to Alex.
Great, thank you so much, Mike, Melvin, Dion, for a great presentation. It looks like we have time for a couple of questions. So audience members, please submit your questions through the chat feature and we should be able to get to at least one or two. You go into the next slide. All right, so as we're waiting for folks to send in their questions, I have a question that I'm going to direct to Dion. All right, Dion, so what initially led you to seek assistance from Illinois ADAP? Am I saying that right, ADAP?
Yeah, what initially encouraged me to seek assistance was transitioning from Charleston, Illinois, which is where I graduated from Eastern Illinois University. And in that moving transition, I had a really nice supportive group there, and I was going to a new region. So I really wasn't sure where to start and begin or where to end. So I turned to resources online that was provided through IPHA, but also to my healthcare provider, and really share my concerns, my fears. Like I walked into the office with my specialist, and I was just kind of like, hey, I'm afraid to move. I'm afraid to go forward because I don't know what I should be doing. I don't know how to make sure that I still have access to the resources to make sure that I can remain undetectable. And if I fall out of some of those resources, how can I kind of get myself back into this health continuum? And my provider really sat with me and provided a lot of paperwork. I still have all those paperwork to this day from 2014, and just kind of sharing where I can go to and connecting me with my case manager that I would be transitioning to in Bloomington. And before I actually moved to Bloomington, I was able to have conversations with my case manager, and my case manager was able to inform me, okay, have these documents, and when we see each other, when you move here, we're well prepared, we have everything that we need, and the transition is going to be seamless for you. And sometimes that transition is not always seamless for everyone. I had my fair shares where that isn't the case, but I think the most important thing is that I come there and I be transparent and tell them that, hey, these are my concerns, these are my fears. How can we help myself, and how can I help myself move forward? But that was really the initial push for me. Once I got connected with my case manager and really started to have that conversation, I didn't feel alone as much as I did when change happens. Thank you.
Thank you for sharing that. I appreciate it.
Mm-hmm.
My next question is, I'm going to direct it towards Melvin and Mike. One of your takeaways mentioned collaboration with other organizations. Can you expand on that? How did you know who to work with or who to reach out to? How did you do that? If you could just expand a little bit more on that collaboration aspect of the takeaways.
Yeah, well, just one of the things that we do, we look online, enroll in different services to see what other events are in community. And as you go throughout the state, looking at other events, other locations that might be having events that might draw your populations. Like I mentioned with IPHA marketing, they might do fashion shows and other things of entertainment value, but just identifying things that might draw your population and then drilling down from there. So knowing that that's going to draw a Latino population at a Colombian festival, for example, and then introducing myself to them, seeing what other events they might have available that might welcome, some places may not welcome public health messaging, but a lot of them are very supportive of that if you're really going to target populations to really drill down more beyond just public health and say HIV, if you really want to expand and reach different pockets of the population. Mike, if you have anything, please.
Well, I think it's really community involvement and community collaborations. You know, I've been at this for a long time, over, 37 years being affected. And, involvement. I'm the Illinois Client Advisory Board rep for the Medical Monitoring Project with the CDC. Many members have sat on the Chicago HIV Planning Group and the Illinois State HIV Planning Group. All of these provide avenues and outlets and resources for you and your clients and individuals to connect for whatever they might need, whether it's mental health, substance abuse, or just a mentor, someone to talk to. So I think, again, community involvement is key.
That's great, thank you. All right, we're gonna do one last question, and it will be for all three of you. So my question is, what contributions to the HIV movement are you most proud of? Anybody want to volunteer to go first?
Mike, you want to start?
Yeah, I would have to say participating in clinical trials. At the beginning, there was no treatment. Doctors were telling you to go home and get your affairs in order because you were going to die. And then luckily at the Cleveland Clinic, I was able to participate in clinical trials, which were testing HIV medications to be then produced, for individuals that are living and diagnosed with HIV. So I think being able to participate in those clinical trials really gave me a personal contribution to the movement that I had put myself out there for other people.
I would say I'm most proud of is the involvement of what Mike said earlier, but kind of going off of that, my involvement with the Illinois HIV Integrated Planning Council, and then also with the HIV Action Alliance. It really does build that sense of purpose and involvement with the community, as well as the engagement. I think my involvement with them was being able to help push the HB 1063 bill forward. It's just beautiful to sit and just realize that so many people came together that just really pushed this bill, and I just want to be a part of that, that effort going forward.
And for me, I would say most recently, probably the work I did with a directly funded CDC grant, which was specifically for African American and Latino YMSM. So I was able to manage that program in the Chicago, Collier counties, and they had no parameters. A lot of these grants have parameters of your regions and zip codes. And so without that as a barrier, if you will, I was able to expand the program pretty far out in the Collier County area and go and meet clients literally where they're at. If it was 11 p.m. At their home, bringing all my programs throughout the area, not just based out of a single facility of an agency. And to identify, I think it was about over 40 African-American and Latino men that had HIV, and bringing them to thyroid suppression, tracking them over 2 years, and to see that they maintained that healthcare, that they stayed linked and virally suppressed, and the impact that has on community viral load. And you can continue to add on that story of the impact of that work, of their success in gaining control of their HIV and moving forth in life. So I think, and then all of the different stories, everybody was so unique, whether it was somebody about to enter college, seeing them graduate and pursue a career in the medical field, all sorts of stories in terms of family bonds, and really to see all of the factors and social determinants of health at play, whether it was someone lost to care and not going down the block to get their medication because of fear of violence in the streets, to losing your job and employment, and you were on PrEP, and due to the break in coverage, they have HIV now. So all of these factors that we, in terms of health equity, because these are all African-American and Latino men, and all of the different things that impact, that intersect their lives, that lead them to get HIV. But being able to succeed despite that moment and move forth in good health.
Thank you. What a great way to close that off. Dion, did you want to add something to that?
I was gonna say something. I'll be remiss if I didn't say this. Thank you
Go ahead.
much. I do want to say also what I'm proud of is the courage and the trust that the individuals who I've met and discussed with on my YouTube channel. There's so many stories. We all know everyone's have their battle, and to be able to connect with people through that, just that communication, and to be able to share that through my YouTube channel has just been, it's been really rewarding. At times when I feel isolated or alone, you know, I look at those things and I'm like, these people, you know, they love me and I love them. And it's just a reminder that we have to, you know, maybe take a break and then get back into the fight. But I'm really proud of to be able to have and be able to do that, to be healthy and to see these people do the work and be a part of their world.
Thank you for sharing. What a great way to end this webinar. Thank you for answering my questions. We'll go on to the next slide and just briefly wrap up today's webinar. So we have 2 more webinars later this month. One is June 17th next week, and the following week on June 22nd. You can register for those webinars on the National Center website that you see linked there. Next slide, please. And we want your feedback. So I mentioned earlier in the webinar that we will be sending an email out sometime next week. We'll link the recording, the slides with all that great information, and we'll also include a link to a survey so that we can hear from you about what topics you want to hear about. Next slide, please. And that wraps us up for today. Thank you so much to the audience for spending the last hour with us. Thank you to Melvin and Dion and Mike for sharing all of this great information, for sharing your personal stories. We really appreciate it. It has been great getting to know you and listening to all the great work that you do. So thank you very much.
Thank you.
Thank you all.
Right.
Thank you.
All right. Take care, everyone.
Bye.